Welcome everyone to this breast education session, part of the VCCC Alliance Research and Education series. I'd like to acknowledge the traditional owners of the land on which we're all meeting and pay my respects to their elders past, present, and any Indigenous people here today. It gives me great pleasure to introduce and chair this session. It's one that we've wanted to do for some time, and I'm delighted that we've got two great speakers, Dean Trotter and Vendela Grufman. The topic is breast reconstruction, and what we have asked Dean to talk about, what it is that a plastic surgeon considers when assessing reconstructive options, and then Vendela on the possibly contentious issue of fat grafting. We have a panel to follow with Satomi and Simon, two other plastic surgeons, so we can have 4 plastic surgeons and 5 opinions on everything. And Belinda and I will be here as well. As always, we'll have a chance for discussion at the end. You can put question and answers as we go, and there is a chat function. So no further ado, I do like to hand over to Dean. Dean Trotter, thank you very much. Dean, well known to many people, many people online, is a plastic and reconstructive surgeon at Royal Melbourne, Royal Women's, and in private around Melbourne, with a particular interest in breast reconstruction. Thank you, Dean.
Thank you, Bruce, and thanks for inviting me. So I'd like to thanks again for inviting me. And I think the talk that Bruce has asked me to talk about is what shapes our approach to breast reconstruction. And so really what I've tried to do is put my ideas down when I see patients into some sort of logical, to me at least, presentation. So with any talk, and a bit of an outline to start, why, when, and how we do what we do. So the why in breast reconstruction is quite clear. There's good evidence to show you have improved self-esteem, body image, and sexual wellbeing scores if patients have breast reconstruction. The satisfaction rates are over 85%, and that's for both immediate and delayed breast reconstruction. So when we're talking about when, today I'm mainly talking about immediate breast reconstruction. So that means that at the time of the mastectomy, the breast is being reconstructed. Delayed reconstruction as well. A lot of what we talk about pertains to that as well, but that's means that the reconstruction is performed after the mastectomy at a second procedure. This slide just sort of sets that out fairly clearly. I'm just trying to find my pointer on the screen. So in this left side of the patient, you can see that they've had a mastectomy before and then they've had a reconstruction. On the right breast, they're having an immediate reconstruction. And the key difference is that the skin is preserved at the time of the mastectomy, meaning that the new breast looks more like the old one. Broadly speaking, in the how, we have implants as one form of reconstruction, the other are flaps. Traditionally, we did the implants in 2 steps. In fact, the first implants were done as single stage. That was around 1958. And then we found there were complications, so tissue expanders was an interim stage. These days, direct to implant is more common, where the implant is inserted directly. Flaps are also performed as a direct thing. Some patients have tissue expanders initially and then flaps, and some patients have implants and then ultimately flaps, but not many people go back the other direction. So the things I think of when I see a patient and the considerations are mainly the patient's body habitus, do they have enough tissue for autologous breast reconstruction? Are there any medical issues that might preclude it? You've got to consider the patient's desires. Do they want big breast? Do they want small breast? Do they want lifts? And these sort of cosmetic issues. Then there's some functional things. Are they high performance athletes? Are they more sedentary sort of patients? The disease characteristics need to be considered, whether the patients are having chemotherapy. Radiotherapy is of particular interest, and I'll talk a lot about that today. The prognosis is relevant as well, but usually the patients come to us having been seen by a medical oncologist, breast surgical oncologist, and that's something that the plastic surgeon, fortunately, has less involvement in. Obviously, the surgeons involved, the skill set of the surgeon who's doing the surgery, and the resources at their disposal. So, as I said, largely what I'd like to do is Bruce has sort of asked me to present it as my approach. So this is sort of the thoughts that spring to mind as I sort of put them down. So when would I recommend no reconstruction? And it's basically patients who have really high BMIs, like this patient in the picture. Patients who have morbid obesity without deflation tend not to do very well with reconstruction of any sort. Patients who can't understand the surgery they're proposing to have are not good candidates, and those with a very poor prognosis. Patients who would be reluctant to offer reconstruction are those who are unhealthy, those with unrealistic expectations. People who are heavy smokers tend to get high complications. People who aren't mentally prepared for the surgery or have chronic pain issues that might be exacerbated by surgery, or they have an unstable home environment where they're not likely to recover well from the surgery and not giving their best chance of recovery. The problem is if patients don't have reconstruction, then they can have significant deformity, and sometimes it's painful. It commonly will impact their function. It's often poorly aesthetic and then leads to psychosocial problems. The other issue is you don't have a reconstruction immediately, then often there's poor access to reconstruction if change of mind. At the end of the day, though, usually if patients are referred, we can perform delayed breast reconstruction. It's almost always an option, regardless of what's gone before. Generally, it will be in tissue reconstruction, particularly if there's been previous radiotherapy. Basically, you need to replace missing skin, such as in this patient here, which results in a more patchwork appearance. So ultimately, the reconstruction tends not to be as good in terms of the aesthetic scores in particular. But functionally, it tends to be okay, although not quite as good as immediate. But pointedly, there's high patient satisfaction from this surgery, so it's certainly well worthwhile. So when would I think about using a tissue expander? Basically, it's patients who aren't suitable for direct-to-implant reconstruction. And these tend to be patients with bigger breasts. There's studies that show once you get over a C-cup, the complications start to increase. I think these days, as we do it more and we're better at it, probably that's around a D. But I start to get nervous once patients have D-cup sized breasts. Those with ptosis or they have other features that might make them poor candidates for direct-to-implant reconstruction, such as being smokers or connective tissue disease, tend to do better with tissue expanders. Those who want bigger breasts, obviously you're trying to expand something that leads to high complications if you use direct-to-implant methods. If the nipple's being removed, then you're removing some skin. That's essentially going to put more pressure on your implant if you make a big skin resection. So there's might be a reason for an expander. And then we talk about sacrificial expanders, which I'll elaborate on later. This is a classic sort of patient in my practice for a two-stage reconstruction. They've had a previous lumpectomy on this side with the deformity. They've got to have further surgery. So we need to expand this. They're having a contralateral risk reduction procedure. So this is at stage 1 after a tissue expander, and then stage 2 after the exchange. The problems with the tissue expander is it's painful. By its very nature and design, it's a temporary device. It can't be in for more than 3 years as per company instructions. It generally results in more appointments to the hospital. It prolongs your treatment sequence. They tend not to look as good as an implant. They have high rates of failure, and they are made of a textured silicon, which inherently may have a risk of anaplastic large cell lymphoma. This is debatable, but we don't know. And there's even some debate whether it interferes with radiotherapy. And in the discussion at the end, I'd be interested to finding out the current views on the radiation oncologists online. So patients who I tend to use an implant on tend to be slim. They tend to have smaller breasts. Nipple-sparing candidates are really ideal. Patients who don't have any ptosis, they have no radiation planned, and obviously they don't have any autologous options. There's also groups of patients who simply don't want scars elsewhere on their body, or they might have a particular aesthetic desire. For example, they might want to look like they have fake breasts. Some patients also like the shorter recovery that implants have. The problem with implants is that they're painful as well. The main issue, though, is I see that over time they don't change. And so patients will find that as their body grows, the implant doesn't change with them, and then they need revision. And essentially, the high rates of revision are the bigger problem. Obviously, they have problems with the devices as well. Sometimes they fail. They tend to move with the muscle that usually is on top of them, and often they become out of position, such as you can see in this picture here. There are some medical issues such as breast implant associated anaplastic large cell lymphoma, which is rare, but it is an issue that we have to consider. And then patients sometimes report breast implant illness, which is maybe not a real thing, but it's something that if patients develop after they've been treated for cancer, then it's a good reason to avoid implant in the first place. So the main issue is that over time you have more surgery. And these days people are starting to perform pre-pectoral breast reconstruction. I can't see that this will confer any great advantage. It might stop animation, but it's likely that with time we'll see complications such as in this patient. This implant's still not going to change with the patient. And we see from the cosmetic world that patients having pre-pectoral implantation have more complications generally in terms of capsular contracture than those who have retropectoral implants. So when would I use a flap? And the answer to that is basically wherever possible. The reasons are it's a more realistic reconstruction. It's soft, it's warm, it ages naturally, and it's mobile. You don't have any complications of an implant. There tends to be less operations over the patient's lifetime. And then there's some body contouring benefit. And if patients need radiotherapy or they've had it, then that doesn't stop you doing a flap. The problem is it's resource intensive. It's quite complicated surgery. There's extra scars and it's a longer recovery. A local flap's when the flap is from adjacent to the defect. So this is mainly seen in the immediate setting with oncoplastic surgery or in the secondary setting with defects such as this. They tend to be smaller defects. You need adequate volume of your flap to reconstruct it. The problem is if there is limited volume and they have limited flexibility, the design is that they have to be connected to their blood supply, which limits their mobility and utility. And often they're actually more complex than you appear. They seem pretty straightforward in the courses and the texts, but actually the rotations and things are often less than expected. So they're not something that we just do ad hoc. In addition, sometimes they're wrongly used, in my opinion, and patients sometimes end up with quite significant deformities when they could have had much better result with bigger surgery such as a mastectomy and a DF flap reconstruction. A latissimus dorsi flap is something in my practice that's used in salvage. This is what we call a regional flap. It comes from an adjacent area, but not right next door. It's mainly used, as I said, for salvage when there's no other autologous options. Sometimes we'd use it if there's institutional or technical limitations. So, there's no microscope at the hospital, for example. The problem is commonly get a seroma at the donor site. The rate of significant shoulder dysfunction is around 7%. The muscle bulk tends to deteriorate over time, and so the result actually gets worse over time, and then they tend to get animated. Most patients need an implant as well, so essentially combining two bad techniques. So microsurgery tends to be the mainstay of the reconstruction in my practice. I haven't gone into what a flap is. I'm assuming a fairly high level of knowledge amongst the audience. But a DF flap in particular is the main procedure I perform, and that's using the deep inferior epigastric artery. And this comes from the abdomen. The other options are from the buttocks and the back. So when would I use a DF flap? And the answer is wherever possible. Patients who desire a natural breast or would like the body contouring benefit conferred from a DF flap are ideal candidates, particularly those with a big pannus or rectus diastasis. As I've mentioned, patients who have had radiotherapy or a plan to have it, it doesn't stop you doing this. And it's a highly sculptable flap, which lends itself to breast reconstruction. It's not always possible. Patients who are too slim, patients who have had prior surgery, or technically it's not always that easy to do. It is a longer operation with a longer recovery, and there's more wounds to heal. A tram flap is the predecessor, if you like, to the DF flap. It involves taking the muscle, and basically I only do this if a DF flap's not possible. So it tends to be, if there's no perforators, what we've got here is a CT scan of the abdomen. The perforator is the vessel that comes out from the main branch and then perforates through the fascia and supplies an area of tissue. So if there aren't perforators on the abdomen, then we would look at using a tram flap if there's not significant caliber vessels that would keep, that work for a DF flap. So in a tram flap, the problems are that you tend to take out a piece of the rectus sheath, which you can see here, once it's repaired, still leaves a significant defect, which has a high rate of hernia and bulging and possibly some functional impairment. Contrasted with a DF flap, which often doesn't damage much muscle at all. The nerves are preserved if we can, and it's a small sheath in the incision. The thigh flaps are called the tug flap, bug flap, and dug flap, and that depends whether it comes from the transverse part of the upper thigh or the vertical part of the thigh in the vertical bug flap. These tend to be used when there's no abdominal flap options, such as this patient who's had extensive liposuction and they literally don't have any perforating vessels in their abdomen at all. Patients who are too slim in terms of their abdominal pannus may have tissue in their thigh, and they're the main patients that I would look at for tug flaps. And you can see a patient like this who has a significant bulge here compared to the amount of tissue in their tummy is a good candidate for a tug flap. A vug flap I would tend to use when the patients want a little bit more volume. Because it's vertically orientated, you can tend to harvest just a bit more tissue. The downside is that you end up with a more visible scar, the tug flaps in the upper thigh, whereas the vug flap, you take this tissue out of the medial thigh and then you end up with the scar that runs vertically up the thigh. The problems with them is, from a technical point of view, that the vascular pedicle that supplies it is shorter and it's of smaller caliber. You tend to need a drain with this, and sometimes even when that's removed, there's a seroma that develops and wound healing complications can then ensue. There is a visible scar and sometimes there's some deformity, which in contrast to a DF or a tram flap, the scars tend to be hidden in the underwear. The lumbar and gluteal flaps both come from the back, the gluteal from usually the upper buttock in terms of a superior gluteal artery flap versus the lumbar flap. These are, in my practice, I tend to use in patients that haven't got abdominal or thigh tissue. So they're third in line, really. Or patients who can't have implants because of radiotherapy. The problems with the SGAP flap is it's, again, technically difficult. The vascular anatomy is usually quite complex and the vessels are quite short. The volume is somewhat limited as well, and it tends to give you a little bit of donor site asymmetry. The lap flaps are a little bit higher up the back, and I tend to use this when the buttock's not as good. The problem with that is it's quite technically difficult. Of all the flaps we do, it's probably the hardest. We tend to use an arteriovenous graft, so it's 2 sets of microsurgery, and the wound sits above the underwear and is visible. So given this is at the VCCC, this presentation, and there's a number of radiation oncologists involved, I thought I'd have a little bit of a delve into the radiotherapy issue. It's evolving and it's controversial. The most important thing, I think, is to treat the cancer. But the principle in my practice is if we can avoid the radiotherapy to the reconstruction, that's a good thing. So quite simply, if a patient's had radiotherapy before, I try to avoid implants altogether. So if it's certain that a patient needs radiotherapy, then I'd like to 100% clarify that. And if that is 100% certain, and this is obviously in the new breast cancer treatment sort of scenario, then I would suggest that they have adjuvant radiotherapy if that's possible. What if radiotherapy is likely but not certain? And we see this more and more. And I think this is really the talking point. There's new tools available. The Decision RT may mean that patients don't need to have it. Bruce hopefully can speak more about that. There's obviously a lot of de-escalation of treatment that's happening now, and we're seeing much more successful neoadjuvant chemotherapy than I recall in the past. And this seems to me to be changing where we're at in terms of neoadjuvant radiotherapy in particular. I think the best thing to do is defer to the multidisciplinary team's advice. But in my practice, I try to offer the best reconstruction available for that patient at that time, and then just hope that they don't need radiotherapy. I use this as a last resort. This used to be a bit of a go-to, I think, which was the idea of a sacrificial tissue expander, where a tissue expander was inserted and then the radiation would be performed, and then usually a flap reconstruction would be performed later on. The problem is I think it's a flawed concept. It doesn't really do what it's meant to do. The tissue expander doesn't preserve the skin in most cases. You often end up with a constricted lower pole. There's commonly failure. Often the expander is not expanded. It tends to obliterate the boundaries of the breast, and it has permanent damage to the pectoral muscle and shoulder girdle. It can damage your vessels, and ultimately there's more operations. It's more expensive. And in some cases, patients have tissue expanders and they don't even need radiotherapy at all. It tends to be painful, and I think even in the main proponent of this, who was Steve Kronowitz, he had a failure rate of 14%, which I would regard as unacceptable. And ultimately, the ultimate result is not as good as it would be had they had an immediate reconstruction, or even had they had a delayed reconstruction. So technically, if patients are going to have post-mastectomy radiotherapy to their flap, so this is a situation often neoadjuvant chemotherapy, surgery, and then radiotherapy to follow. Some patients, I think, do better than others. And I think the patients who have donor sites bigger than their breast tend to do better. That tends to leave no dead space in their breast. Having consistent flaps, both mastectomy skin flaps and your reconstructive flaps, is really important. And then having consistent radiotherapy as well. We're lucky we get that in Melbourne, but I do see in different centres the radiotherapy delivery is different, and sometimes patients are affected more than others. Certainly, radiotherapy may shrink the flap, it may make it stiffer, but generally we can fix that with fat grafting. And this sequence of pictures shows that over time, there's really no change to the flap in this particular patient, showing that you can irradiate the flap without significant change. Here's another example of that, shown at 12 months. And this works for other flaps as well, such as the tug flap. The problem is if you don't get the reconstruction right and then you irradiate it, it tends to do badly. And this patient's an example of that, where they've had an undervolume reconstruction. They also have a hypertrophic scarring tendency, and then they've had radiation and it really never settles down. And so unfortunately, this patient's consigned to an inferior result, and perhaps neoadjuvant radiotherapy may have been a useful thing to do. The radiotherapy effect can be a little unpredictable. And as I said, the failings of the reconstruction can be exacerbated. If patients have neoadjuvant radiotherapy, then we tend to see reasonable results with their reconstruction. It does allow time for planning and education, which is quite important. And it doesn't have any risk of delaying your adjuvant treatment. And you can see that you can get quite good results without significant complications. One thing I do tend to see in this setting is often they get quite a lot of swelling. Patients sometimes get lymphedema and sometimes pain. And unfortunately, in a group of patients, this doesn't resolve. I'll move on just to a couple more topics to finish off, just in terms of my approach. So if we have a large patient who's presenting for a reconstruction, then what I'd like to see is that they have deflation of their skin envelope. I think careful selection of your patients can lead to reduced complications and good overall results. In the case of breast reconstruction, usually that means adjusting the mastectomy skin flap, such as in this patient, we've performed quite a significant reduction with a big flap island, and you can see over time that blends in quite nicely. In this patient, we might have adjusted the abdominoplasty as well as the breast reduction to minimise our complications. One thing that I found quite useful is a Prevena dressing to reduce the tension on the wound and reduce the complications in these larger patients. Finally, I'll finish with nipple-sparing mastectomy, and my approach to this involves answering a few questions. Firstly, is it oncologically safe to do so? And it's always nice to get a letter from the breast oncologist who says nipple preserving is possible or not. If it is a safe thing to do, if the nipples are in the right spot, well then this is what I would tend to prefer. Sometimes though, it's possible to move the nipples, and that's a question then for the patient of how many operations are they willing to undergo to try and have their reconstruction. If the nipples aren't in the right spot, then you need adequate volume generally to try and restore them. And so if the nipples are to be put back where they should be, you tend to need to put as much breast volume back in as was removed. So here's a good candidate for that procedure, and she's had a nipple sparing mastectomy through the inframammary fold. She's got a bigger tummy than breast. You predict that she does well. In terms of the nipple sparing approach for the mastectomy, it can be hard for the breast surgeon to dissect from the inframammary fold to the top of the breast. So in patients with ptosis or a significant distance in terms of height of the breast, then we prefer to go through the breast, and that tends to leave quite good scars as well. One thing that we can do, and we can consider if the patient's referred, typically only in the risk reduction setting, is patients who haven't got their nipples in the right spot. We put them in the right spot with a breast reduction, and then that allows us to do either a DF flap or a direct to implant, which may not have been possible beforehand. So I'd like to thank you for your time. This is one of our plastic surgery journals, the ABC of flaps, and I'd appreciate your questions. Thank you.
Thanks, Dean. That was really good. So we do have a few questions now, and so we might address them and then more time later on. So one question from Carolyn is, please address the issue of BMI and DIEP reconstruction. There's considerable variation amongst plastic surgeons as to their standards. How do you address that question? And if either Simon or Satomi want to comment, please do.
Yeah, I'll give the others a chance to talk, but in my practice, we did a study at Royal Melbourne that showed a BMI of 38 or under. The complication rate was about the same. So that's the first thing. The second thing is the deflation issue. BMI is a bit irrelevant in my view. I think the main thing is that does the patient have a deflated skin envelope? The more deflated, the more it lends itself. But I'd appreciate Simon and Satomi's comments as well.
Simon or Satomi?
Hi, it's Satomi here. From my limited experience, and obviously I worked a lot with Dean and Simon through the Royal Melbourne, where I do see probably a lot larger patients. And what I've learned from Dean and Simon is, like Dean had mentioned, the abdominal pannus makes a really big difference in the complication rate and the healing process. So even if the patient's BMI is relatively high, if they have a significant pannus that just hangs there and you can comfortably close the abdomen, I do find those patients will actually do quite well and have a low complication rate. Where the patient has just got a really large intra-abdominal fat where they've just got so tense and tight in the abdomen, if we take a significant amount of tissue off, then they'll have a significant complication or healing process post-operatively.
So that does come to another question, which does relate to the abdominal wound complications. Is that the main issue? Is it whether the abdominal wound will come together under no tension? Is that the best predictor of smooth recovery, or are there other factors?
Can I make a comment there?
Sure.
My camera has been switched off, but it's Simon Overstall here. I think the tension-free closure of the abdomen is far more important for the obese patients. It's amazing, on a relatively skinny patient, you can close the abdomen under a huge amount of tension and require the bed being bent to 90 degrees, and they seem to do just fine mostly. Whereas, yes, in the obese, where there is particularly intra-abdominal fat that's creating more of an apple shape rather than a pear, where there's a lot more tension on the abdominal closure, those are the ones that really seem to struggle.
Okay.
In my practice, I don't stop doing DIEPs if the patient's got a BMI of greater than 30 or greater than 35, but it is important to have a discussion with them beforehand, just to let them know that they are at a significantly higher risk of abdominal complications. But in my experience, even if there is delayed healing of the abdomen or even a dehiscence requiring further surgery, once that's all healed, which it always eventually is, most of the patients look back and are still happy with their decision.
All right, question from Belinda, who's here, is that bilateral DIEP sometimes chosen by patients given the one-off option, i.e. a second DIEP's not possible. Comments on the difference in recovery between unilateral and bilateral DIEP? Is it twice as long, or is it no different?
I think it's not much different at all. You do have another breast though, and so there is another front, if you like, to heal. Not all DIEPs are the same. Sometimes there's muscle taken, sometimes it's a tram flap. And it does make the operation longer. And there's a surgical variation. At Royal Melbourne, I think we average about 7 hours or something for a bilateral DIEP and about 4 for a unilateral. So, but that time in theatre doesn't seem to correspond with any extra time on the ward or in recovery. There must be a little bit, but it's not really measurable, would be my view.
Okay. Thanks very much. Thanks.
Yeah, and I think certainly if the patient is considering potentially having a prophylactic mastectomy at some stage, it makes much more sense to do it all in one as a bilateral, rather than doing a unilateral DIEP flap and then a year or two later you're scratching your head trying to find a suitable donor size that would have worked really nicely with a bilateral DIEP.
It does feel that we're doing them more now than we did 10 years ago. Like following international patterns, bigger demand, and I'm certainly doing some more.
And patients are considering this more. Certainly, patients are considering this more. You know, they come and see you and they see the amazing results, and then they're thinking, well, exactly what Simon just said. Yeah. Can you see the questions in the Q&A, Bruce?
Yeah, I can. So there's one to you actually. So it's from Gillian Farrell. Does neoadjuvant radiation prior to mastectomy that Dean referred to exclude some patient from access to treatments and or trials for their breast cancer? So from a medical oncology point of view, do you have views about this, our move to use neoadjuvant radiation?
Well, so I think what Gillian's perhaps referring to is the fact that we now have survival benefit from tailoring systemic therapy by using a neoadjuvant approach. So in the old days, we gave the same treatment before and after surgery, and of course the survival was the same. But now, depending on your response to neoadjuvant therapy, we can tailor the drug therapy in the adjuvant setting, and it does make you live longer, which is pretty important. So if the important thing is to find even a minute part of residual disease after a neoadjuvant regime, which requires surgery, then that is a priority. If that, there are talks about doing that another way other than proceeding with the complete breast surgery, such as doing biopsies, but it gets rather complicated. So look, I think the truth is the survival data from neoadjuvant really has placed neoadjuvant radiotherapy in somewhat of a difficult position, but certainly not impossible. I would argue that in the HER2 positive space, it's probably causing more challenges than the triple negative and the ER positive. But yeah, that would be my answer to that.
Good. All right. We are at 6:05, so I think we might ask Vendela to speak now, and we'll have some time for further questions at the end. So welcome to Vendela Grufman, who arrived in Melbourne quite recently from lockdown-free Europe to lockdown continuing Melbourne, but it's very good to have you here. And we've asked Vendela to talk about fat grafting, the good, the bad, and the ugly. Over to you.
Good evening, everyone. Can you see my screen?
Yes, we can.
Perfect. And you can hear me as well? So thank you so much for having me to talk about lipofilling and breast reconstruction. The topic reads the good, the bad, and the ugly. I'm not sure if I'm gonna fulfill the part of the ugly, but we'll see in the end. So I've just arrived from Switzerland, where I was working with GM Ferrati, and he did quite a bit of lipofilling in breast reconstruction. So I hope I can share some of the knowledge I got there. Why is fat a good filler? It's readily available in most patients. It's quite easily obtainable with a low donor site morbidity, and it can be done repeatedly in patients. It's quite inexpensive. It's versatile and it's also biocompatible. So it seems like the ideal filler. The first description of a breast reconstruction with a fat graft was as early as 1895. Mr. Cherney described taking a lipoma from the back, and he replaced part of the breast with this lipoma. Unfortunately, his results weren't that good, and people that were copying him didn't have good results. So it took almost 100 years before the technique became popular again. And it was a Dr. Coleman who described techniques of harvesting the fat and also injecting the fat in a standardized way. And he could show very good results, and that made it popular again in the 90s of the last century. So what about safety of lipofilling in breast cancer patients? There are many in vitro studies that have shown that the lipoaspirate is capable of cell stimulation and promoting cancer growth. So the fear is to wake up dormant cancer cells, and in doing so causing a higher risk of local recurrence in breast cancer patients. However, there is a contradiction between experimental studies and clinical studies, and we still lack prospective data on this topic and a long-term follow-up. And the data that we have from present studies, they show incomplete data and quite inhomogeneous groups. So this is just 3 studies, pretty recent studies that I've picked out that show data on the safety of lipofilling. The first one is a group from the MD Anderson Center, and they looked at their result from the last 30 years, where they did lipofilling after mastectomy, and they also found or matched their group with a control group. So they looked at over 1,000 patients, and they did find lipofilling to be safe in these patients. The second one in the chart is a Spanish paper. It's also retrospective, and they also found lipofilling to be safe after mastectomy. However, they said that the interval between primary surgery and the lipofilling should be more than 3 years. Otherwise, it's not deemed as safe. The last study in this chart is one made by Furch and Andre in Düsseldorf, and they matched 100 patients with 100 controls, and that was after mastectomy and a diaphragm reconstruction. They also said that lipofilling is safe. However, they found a subgroup where the local recurrent risk is higher, and that's in nodal positive patients and patients with a high-grade neoplasia. So this is the Kaplan-Meier curve for these patients. Lipofilling is marked red, and you can see that the survival for the upper one is the nodal positive group, and the lower graph is the high-grade neoplasia group. That's different to the other one. So what about the safety of lipofilling after breast-conserving surgery? This is a review that was done in 2019, where the authors really scrutinized the studies present on this topic. And they found 19 studies, but due to several design limitation, the author said that they cannot prove oncological safety of local recurrence after breast-conserving surgery. But they were very, very strict. So what they're saying is maybe it is safe, but due to the limitations, they can't give their absolute go. So what we end up with is that we have no formal conclusion regarding the safety for every single patient. And that's why we have different recommendation in different countries. So these are the NICE guidelines from the UK, and they're actually not that strict. They say that lipofilling after breast reconstruction can be used without any major safety concerns. They do, however, say that the therapy has to be a part of a multidisciplinary team, and the person or the surgeon performing the surgery should have a specialist expertise and training in the procedure. France sees this a bit differently. They're much more strict. They tell us that you shouldn't perform lipofilling after mastectomy if there's a high risk of recurrence. And after breast conserving surgery, they always wait 2 years before performing the first lipofilling. For breast augmentation patients, they also want a negative family history and no genetic mutations in the patients. So in Switzerland, we've chosen a bit of a neutral way, like Switzerland always does. So in Switzerland, it's also the recommendation not to perform lipofilling in breast conserving therapy within 2 years of the primary operation. So we always wait 2 years. However, in genetic positive patients or in patients with a positive family history, there is no strict guideline. You just have to inform the patient, and you can still go on with the procedure. So what about radiological findings after lipofilling? Does it interfere with the diagnosis of recurrence? This is a review that was done in 2020, and they sum up and say that the changes that arise after lipofilling are predictable, as they're induced by physiological alterations, and that they're easily recognized as benign lesions by trained radiologists. And if there is any doubt, an MRI should be conducted, and if suspicious lesions occur in the MRI, a core biopsy. So now to the next part of my talk, about the optimizing of the fat graft survival, because that's the major problem when performing lipofilling, that the outcome is not always consistent. So you can't really tell your patient how the outcome is going to be. And in order to get as good as outcome as possible, it's important to perform a standard fat grafting technique so that you always perform it in the same way. And more or less all plastic surgeons use a standardized Coleman technique, which consists of 3 stages. It's the harvesting, processing of the lipo, aspirate to eliminate cellular debris, and then injecting the purified graft. So the first thing that we do is infiltrate the donor site areas. In Zurich, in Switzerland, we did not use any local anesthetics. There are papers on the topic saying that the lidocaine leads to a decreased adipocyte function. Others say that it's not a problem because you wash the fat afterwards anyway, but we only use saline and adrenaline. Here in Melbourne, I've used lidocaine as well. The harvesting technique, that's also something that different surgeons do differently. Usually you would want a graft size of approximately 2 millimeters. Why is that the case? Well, the graft has to find its way to some blood perfusion in the vascular bed. So if the fat lobules are or the graft is too large, central necrosis will develop, and fat necrosis will follow. So we usually use 3 to 4 millimeter cannulas with small openings. What about vacuum pressure? You would not want a too high pressure because that also leads to a decrease in adipocyte function. You can use a power-assisted liposuction. You should just do it not with too much pressure. The preparation of the fat can be done quite differently. A couple of years ago, probably most groups were still using centrifugation. That's not done that commonly anymore. You can still do it. If so, you should just be aware of not centrifugating too long. What we usually do is just to wash the fat to eliminate the debris, and then later do an on-table decantation. And these are systems that can be used. It's probably not that important which system you do use. You should just be acquainted with it, and it just eases the work while performing the lipofilling. So now to the most important part of all these steps, that's the injection. And this should be done in a retrograde manner. We call it retrograde spaghetti. So whilst pulling the syringe or the cannula out of the recipient bed, you infiltrate. And it's just really important not to overfill the breast, because that will also lead to fat necrosis or old cysts. And it's important to do it in different layers, as seen here in the picture on the left, and in a fan shape to really disperse the fat in the recipient bed. So just to sum up the golden rules, it starts with infiltrating with or without local anesthetics, then harvesting with not too much pressure, using small cannulas with small openings. Then the washing of the fat is important, centrifugation, yes or no, and depositing the fat in different layers in a retrograde manner. Now I'm going to show some cases and different indications of the lipofilling. This will just give you an overview over the most typical cases that we see in our practice. The first case is a slender patient who's prior to this had a mastectomy, and the skin is almost glued, as you can see here on the left, glued to the chest wall. And to soften up the soft tissues for an implant reconstruction, which this patient wanted, we did 2 sessions of lipofilling. And here on the right, you can see that the skin has improved a lot in quality. Second patient is also an implant reconstructive patient. However, she's already had her implant, and you can see in the medial part of the breast there is a dent, and also the transition is not that soft. And this is how she looked after 1 session of lipofilling. And this is the lateral view, where you can see it definitely improved a lot, just the transition in the lower pole. Next patient, also an implant reconstruction case where the implant almost seemed glued to this very, very skinny patient. And the transition in the upper pole in the cleavage area was softened with lipofilling. It's not a lot that you get out of these patients, but you don't need a big amount, probably around 50 cc per breast to just soften the transition. The next case are all autologous reconstructions. So this is a young patient with a bilateral TMG or tug flap, so from the thigh area, and she had a nice result after autologous reconstruction. However, she had a bit of an asymmetry, and don't know if you can see this. There's kind of a dent in the medial aspect of the right breast. So we did some lipofilling and filled more on the right side, and got a nice result. This is also a patient, this is prior to also TUG reconstruction. And she also had an asymmetry after the flap surgery with a bit of a volume deficiency in the left lower pole. And that was also corrected to some part with lipofilling. This is a patient, she did not want an implant reconstruction and she did not want a flap reconstruction. So she actually convinced us just to go with the lipofilling. And this is her after her nipple-sparing mastectomy and simultaneous lipofilling, only with 120 cc. And then this is after her second session, third session, fourth session. And we could always fill more and more because obviously the recipient bed became larger and larger. And this is after the fifth lipofilling, and this is where we stopped. So it's quite a nice result, but nothing we usually did because it needs a lot of perseverance from patient side and also surgeon side. The last case is a patient with a tumor in the lower medial quadrant, and she qualified for a wide local excision, and she then also had some radiotherapy. So this is how her breast looked after radiotherapy, and with actually the complete lower pole was more or less missing. So we did a few sessions of lipofilling and rigotomy, and this is the result after the fourth lipofilling. So not a perfect result. You can still see some contour or bumps, but she was happy. And now to the ugly. So this is just something that Gianferrati did a couple of years ago. In implant reconstructions, he did a first stage expander implantation, and he during the first stage also did some lipofilling to the pectoralis muscle and placed the expander in a subcutaneous plane. And he did this to thicken the pectoralis for the second stage, which was after approximately 3 to 6 months, where he exchanged the expander to an implant, but placed it in a subpectoral pocket with an ADM just in the lower pole. And the idea was that in very skinny patients, the pectoralis would just cover the implant in a better way and also prevent rippling in the upper pole. The problem was that by filling fat in the muscle became super brittle, and it was almost impossible to prepare the pocket during the second stage. So that's an indication where lipofilling definitely is not a good option. Thank you so much.
Okay, that was really good. A lot of us hear about lipofilling and don't know too much about it. I thought the summary of the safety advice was really very interesting. Are they guidelines that are generally followed in Australian practice, Simon?
I think there's certainly a fair amount of variation in people's philosophy in fat grafting. For a while, medical indemnity insurance wasn't covering any fat grafting into native breast tissue, so it was fine to use in reconstructive. cases, and particularly around implants or around the edge of Dieppe, but it wasn't used for breast augmentation. And I think the rules on that seem to have been a little bit relaxed, in that I know more and more people who are using it routinely for breast augmentation, but I think they're still in the minority.
But the idea of avoiding it in the first 2 years, particularly in high-grade and node-positive cancers, is that something that?
No, that's not something that I've seen anyone practice here, and it's certainly not my practice. We would use fat grafting from an earlier.
So we sort of assume that there are not oncological safety issues. That is my impression, that that's the way people are practicing. I don't know if others have strong views on that. I thought it was interesting that the various European countries did seem to come to that conclusion.
Yeah. I mean, I've often heard it debated at conferences as to really what the oncological sequelae are of this, but my understanding is that most people feel that it's unlikely to cause increased rate of recurrence or the development of new breast cancers. But the most significant issue is potentially muddying the waters when it comes to ongoing surveillance. And quite often these patients would end up with extra ultrasounds or extra biopsies because a lesion has shown up on the breast, which is quite possibly an oil cyst or a bit of fat necrosis, but no one's really.
So that comes to the. I know that our radiologists don't like fat grafting. I think it's because they see the numerator. They see the cases where there is a lump or something that is sent for imaging. And my question to Vendela is, in what proportion of cases of fat grafting is there a palpable abnormality?
I definitely think that it depends on the surgeon. If you don't overfill the breast, then you should not as easily cause an cyst or lump or necrosis. Of course, it can happen anyway, but then you know where that is and in which location it should be subcutaneous, because you should probably fill it in a subcutaneous plane, not in the gland. So it should be possible, if you speak to the radiologist, and to distinguish if it's benign or if it's possibly not benign.
Yeah. What about the frequency question? I hear what you say, but is this a 1% of injections lead to a palpable abnormality, or 10 or 20?
I would say it's around 5 to 10%.
Yeah, and Carolyn, it's the same question. The challenge is differentiating between fat necrosis after lipofilling and a local recurrence. And we've just got Alexander Brown quotes a number 2.2% over 4 years at Westmead. Like the clinical issue is there is a lump. It's most likely to be related to the reconstruction, but most likely doesn't mean necessarily. So we are often forced to investigate.
Yeah, what I would say is often Dieppe flap or other autologous flaps, I think patients are more likely to have a palpable lump from a bit of fat necrosis around the periphery of the flap than after fat grafting. With fat grafting, they, certainly in my practice anyway, they tend to have not really particularly palpable lumps, but things that would show up on an ultrasound scan or various other imaging modalities. Whereas the palpable one's more common with flaps. Okay,
we've got a couple of questions. We've got one from Michael Chow. Do you have any figures for fat necrosis and fibrosis post-immediate autologous recon? And do you think it's similar to neoadjuvant RT? Is this the case for all surgeons? So fat necrosis,
In autologous or after lipofilling?
No, this is back to Dean's presentation, autologous. Numbers of frequency of fat necrosis, and does radiation affect it?
I would have the figures from Zurich. We had, after DF flap reconstruction, we had a fat necrosis rate of 23%, which is quite high. However, we measured everything that was over 5 millimeters with sonography. So palpable lumps that we actually removed was only half.
Okay. Yeah, Dean.
It is an interesting thing. I mean, fat necrosis is like Vendela. It's good that they've looked at that, with an objective measurement, because you do read that in the journals, and there's a lot of subjectivity to it. As Simon said, it's very common around the margin of a flap to feel lumps, which is fat necrosis. But most of them go away with time. So there's a time element to it as well. So if you look at people soon on afterwards, then they will have fat necrosis. And I guess that speaks to Michael's question, and that's my point, is that I think if you have that fat necrosis around the margin of your flap, it does tend to go away. But then if you irradiate it, it tends to make it persevere. So I'm not sure whether that quite answers the question. As opposed to if you do neoadjuvant radiotherapy, then what I tend to see is fat necrosis in the mastectomy skin flap and lymphedema in the skin flaps, which don't tend to go away. So I think it's a different problem. One's more problem related to reconstructive flap. The other's a problem of mastectomy skin flap.
Yep. Okay, and a final comment from Kenny Elder, long-term Edinburgh, less than 5%. This lessens year on year as the technique has improved, and the radiologists have become more comfortable over time. So fewer biopsies needed. And some back to a comment to Dean, question to Dean from Farshad. Thanks for the comprehensive presentation. If your hope of avoiding RT doesn't happen, which reconstructions do best with post-mastectomy reconstruction? And I think he's talking about, of the autologous, do some have better vascularity than others?
No, I think the best ones to tolerate are well vascularized flaps. So a carefully planned flap, whether it's a DEP flap or a tug flap or a SCAP flap or whatever, as long as it's well vascularized when it's harvested. And we can use things like the SPI-FIRE to try and analyze that. And there is surgical experience to that, and making sure that you're not transferring fat that's not healthy is the main thing.
Okay, good. It's just on 6:30. I think that's been a fantastic session. I've learnt quite a lot, and I'm sure lots of people have. Thank you to both speakers, Dean and Vendela, for those great talks, and thanks to Satomi and Simon for joining. Once again, thanks to the audience, and I don't know if we've planned the next one. There will be another one, and you will hear about it, and Belinda's going to organise it.
The next one's in November. We had a plan for one next month, but it's getting in the way of a couple of breast events. So yeah, we'll see you in November. Thanks very much, all of you. That was a great session. I did learn a lot too.
Thank you.